If you live in this state, you discover that 98% of people have an insurance policy. According to the most recent Boston Globe poll, most people support the bill. Few people have thought of repealing it. And the purpose of the governor's talk today is the anxieties have to do about the long-term financial viability. This is the 5th year anniversary, and to borrow a phrase from Winston Churchill, the 5th year anniversary basically marks the end of the beginning. And it's time for chapter 2, and that is what the governor is going to talk about with us today.
Having insurance premiums rise sharply year after year, even during the recession, is a national problem. It's not happening on account of health care reform. Some of the conservative commentators want you to believe that it is happening because of our health care reform, but they're wrong. And just as we have shown the nation how to expand coverage to everyone, I really believe Massachusetts is going to be the place where we will crack the code on cost containment. It won't be easy, but promise you, it will be done. It will be done. So
the fact that he came here for our school is incredibly important because the advisory work done on that legislation was done by our faculty.
We are going to have to solve this problem of health care cost by all of us, private and public, working together. And we have got to stop being defeated by the complexity of the issue. Nobody takes any responsibility for it because it's complicated. Okay, we could spend the next 2 years peeling away all that complexity. I'm done. I'm not interested anymore. We're moving. Something has got to give.
Actually, one of the features of this program is that we have online questions. So I'm going to ask a question from an online viewer. Somebody has on the iPhone here. And this is Melissa French from the University of Liverpool Master of Public Health Program. I am interested to hear your framework and intervention design methods that led to the approval of the Massachusetts health policy. Would you suggest this approach for lower income states or areas?
Melissa?
That is Melissa.
Melissa. Yes. So what time is it there? So Melissa, hello from Boston. Our reform is the model for national health care reform. I'm proud of that, and I think it can work and will work nationally. I think we had some advantages, and one is, compared to many states, we started off with a relatively small uninsured population, right? So we were maybe 500,000 uninsured on a population of 6.5 million.
He had never been, as governor, in a situation where people from another country were asking him about his policy, which shows how even for someone as sophisticated and experienced, the technology of going global has allowed the discussion to change for people who are actually speaking here. We were able to combine the governor's talk with experts who were responsible for implementing this legislation over the last 5 years. Here, an audience could actually see the political leader talking about moving ahead, and then the people involved with implementing that, discussing the issues, all in one venue. And that's what really was important. You combine the two. It's not two separate worlds. It was one world for someone who viewed this event.
We had everyone who was important in making this into a reality right there discussing the nuts and bolts and also the aspirations.
So in this culture we have, choice is king. You know, choice tops everything. And choice is really not good for you sometimes. So it's a real challenge, the idea of trying to educate people about things that, right care, right time, right place.
My sense of your question is, how do we go about the process of educating consumers so that it's not just a question of choice, but it's informed choice, right? And we intend to get deeper engaged in that inside of the communities that we represent to begin to do work.
And I agree, a lot of health prevention is in the environment around the person, so you can't just change behavior of any one individual. You need to take a community approach.
The way to do that, I think, would be through ensuring that the outcome measures that are an important component of the way that the accountable care organizations are evaluated and reimbursed don't only include clinical measures, but include community health measures as well, or activities that might push beyond the comfort level of the current way that we provide clinical care. Would that work?
And I think, exactly, I think the metrics could certainly reflect community health metrics.
So one question I have has to do with primary care. I'm a medical student and doing my MPH this year, and I've found that not many of my classmates will be going into primary care. And so I wanted to know what you think we need in the physician community to encourage more, create more incentives.
I mean, what physicians really hate, primary care physicians, from what I understand, is feeling like you've got to see a patient every 15 minutes, or you're not going to be able to meet payroll or pay your rent because the fees are so low. We do have to get away from the fee-for-service treadmill.